Okay, so we are live. Is anyone in? Hello. So I think we are more than usual. Okay, hi Karen. Lucas is here as well. Anyone else? P Chips, okay. Hi P Chips. We will start in 2 or 3 minutes. Hi Lucas. So, how was your week? Thanks Lucas. How was your week? Where did you find the pain points? Also, Karen, how was the newsletter? Did it help? P Chips, I think it's the first time you are in, so hi. Let us know if you have any questions on any topic. Okay. So, do we have even more students? That's great. Let us know your name, because this is an interactive course, so we need you. So write something in the chat. Skunker. Cancer risk factors in OBGYN. Okay. Also, Skunker, if you want to be part of the newsletter, let us know. NP Chips, we have a weekly newsletter with summary sheets on various topics. For example, I think 2 weeks ago we had an OBGYN, and the last week was, no, actually this week was on fundoscopic findings. Okay, so in 2 minutes we will start. Okay, so if you want to be part of the newsletter, let me know at hi Shemi, so Shemi also. So send me an email stating that you want to be part of the newsletter at this email. This way you can receive weekly the newsletter. I will wait for your confirmation on the receival of the email, and then we will go and study neurology and OBGYN. Okay, so let's start. First, thank you that you came here. Now, let's focus on the science. So, we will start with OBGYN. We have a 35-year-old woman, G1P0, at the 10th week of gestation, comes to the clinic with an abundant lower genital tract bleeding. The patient describes mild cramping on movement. The clinician decides to pursue a speculum examination, seeing an open cervical os and fetal tissue exposed. What is the best next step in the management of the patient? We administer misoprostol. We do a dilation and curettage, pelvic rest for 24 hours, or D, cervical circlage. Oh, I'm so sorry. Okay, let's start again. A 35-year-old woman, G1P0, at the 10th week of gestation comes to the clinic with an abundant lower genital tract bleeding. The patient describes mild cramping on movement. The clinician decides to pursue a speculum examination, seeing an open cervical os and fetal tissue exposed. What is the best next step in the management of the patient? A. Administer misoprostol. B. Dilation and curettage. C. Pelvic rest for 24 hours, or D. Cervical circlage. Let me know in the comments the answer. So we have 2 dilation and curettage. Okay. What are the others' opinion? Lucas, B. So okay, so I think this is unanimously B. And could you explain why you chose B? Shemi. Okay, so everyone agrees that this is B. The question is why you removed all the other answers. Okay, so we have a possible risk of septic abortion. That is a good one. What is the diagnosis of this patient? Pelvic rest is indicated for PROM, and cervical circulation is for cervical insufficiency. Okay. I really like your answers. Firstly, indeed, there is a risk of septic abortion. Indeed, circulation is for insufficiency. And misoprostol for induction. Now, these questions on USMLE are quite tricky because there are multiple types of spontaneous abortion. The treatment of the spontaneous abortion is dependent on the type. By answers. Misoprostol is administered if the patient has spontaneous abortion at more than 12 weeks. Dilation and curettage is the correct answer. Pelvic rest for 24 hours is used for a specific type of abortion, and cervical circulage indeed is used for PROM. The answer is dilation and curettage. The patient presents with the classical findings of an incomplete abortion. This consists of mild cramping and bleeding. On the speculum examination, we have viable tissue. The treatment is dependent upon the gestational age. Less than 12 weeks, we do a dilation and curettage or manual uterine aspiration. More than 12 weeks, we administer misoprostol, or we have an expectant management in the hopes that she will eliminate the remaining the product of concept. This type of question will test your knowledge on different types of abortion. Firstly, we have incomplete versus inevitable abortion. On the physical exam, both are with an open cervical os and both have mild cramping and bleeding. From the diagnosis part, we should see a fetal, we should see the product of concept on ultrasound inside the uterine cavity. Now, the differential diagnosis between incomplete and inevitable abortion is the fact that the fetal tissue hangs out of the uterine cavity in incomplete abortion. In the case of the inevitable abortion, the fetus is still inside the uterus. The treatment is, as we've discussed, dilation and curettage or manual uterine aspiration at less than 12 weeks. More than 12 weeks is a treatment with expectant management or misoprostol. And if we have inevitable abortion, we use the treatment from the incomplete abortion from 12 weeks on. There is also a threatened abortion, which also has an open cervical os and bleeding and cramping. For the diagnosis, we will have the fetus inside the uterine cavity on the ultrasound. However, the treatment for threatened abortion is a pelvic rest for 24 to 48 hours. Then we follow it up with ultrasound to see if it either developed into an incomplete abortion or inevitable abortion, or if the threatened abortion actually remitted. The most easiest concept is the complete abortion. On the physical exam, the cervical os is closed. The bleeding is already resolved by the time the patient arrives in the ED, and there is some mild cramping. However, the diagnosis is made with ultrasound with no fetus inside the uterine cavity. It already underwent expulsion. And the last type is the missed abortion. We have a closed cervical os, we have no bleeding and some mild cramping. However, the fetus in this case, although present in the uterine cavity, has no cardiac activity. In this case, we either expect the expulsion or we administer misoprostol to induce expulsion. So, was I clear? Do you have any questions? Super. What is great about misoprostol? When would tocolytics be indicated? Generally, Karen, are you? To answer P-Chips, in the case of complete abortion, there is no treatment. The patient has already the fetus exposed. On the other hand, if there are remnants at speculum examination of the placenta, we will do a manual excision of the remaining placenta due to the risk of amniotic fluid emboli. Otherwise, for complete abortion, there is no treatment. To answer Karen's question about tocolytics, so tocolytics are indicated if the patient is less than 36 weeks of gestation. We administer tocolytics if the patient is stable hemodynamically in order to let the corticosteroids such as betamethasone or dexamethasone to act for at least 72 hours. This enables lung maturation in a possible preterm delivery. Okay, so with pleasure, Karen. Now, we are ready to go for the second vignette, and this time the vignettes were made by the model of cascade questions. I think you all are already used to them. They are frequently seen on step 2, one after the other. I think we've lost 2, Shiemi and Skunker. Hopefully they will reconnect. Okay. Now, you perform DNC on the patient aforementioned. She comes back to the clinic 8 months afterwards, complaining that no menses have occurred since the abortion and that she did not manage to remain pregnant despite an unprotected intercourse for the last year. On hysteroscopy, there are adhesions at the level of the uterus. What is the next step in management? We give OCPs, we schedule a follow-up at 12 months, we do a hysteroscopic lysis, or we introduce an intrauterine device. CC. Okay, from now on, when you give the answer, please also write why do you think is that answer. Right, exactly, it's Asherman syndrome. Do we have other answers? Lucas, Shemi, are you still on? Maybe not. Okay. The answer is hysteroscopic lysis. Asherman syndrome is characterized by the presence of intrauterine adhesions. Adhesions and amenorrhea or infertility leads to the diagnosis of Asherman syndrome. Usually these type of adhesions occur after trauma, dilation and curettage, or postpartum. The diagnostic tool that we will be asked on USMLE is the ultrasound. It will show a thin endometrium with hyperechoic regions. However, if we are asked about the most accurate test or the one that will put the definitive diagnosis, we will use hysteroscopy as an answer. The treatment is either observation for patients that do not require childbearing. Women that want to have a child will undergo hysteroscopic lysis. Okay. Well, I'm glad that you all got both answers right. Do you have any questions on this disease? Lucas, don't be so how can I say? Don't be so happy because we will change topics. None so far. Okay. I hope you enjoy the course up until now. We will take a little break. It's a short break between the two topics. If you like this, please subscribe if you're not subscribed. If you want to become part of the newsletter, as I've told you, send an email to Medical Perspective blog and you will receive summary sheets on various topics to review before your rounds or to review for step 2, for step 1. If you think that this course will help other students, please recommend it. As you see, we are like a class of 5, so I think that more people will benefit from this course if you'd like to also. Short question before going into neurology. Does anyone know what type of animal is that one? Exactly, it's a sloth. It's a sloth. Their metabolism is actually extremely efficient. Yep. They consume very few calories. And that is due to the fact that they are eating just leaves. Okay, are you ready for neurology? Wait for a change of pace. Okay. A 35-year-old woman comes to the ED due to double vision. She has a history of relapsing vision loss. Also, she states that she has a rare tingling in her hands. This tingling is more prominent after a bath. On the oculomotor exam, the patient is unable to adduct the right eye to the left when looking at the left. On the other hand, when looking at the right, the left eye remains in neutral position. Where is the lesion causing this patient's diplopia most likely located? On the optic nerve, on the pathway of the third cranial nerve, on the pathway of the sixth cranial nerve, or in the medial longitudinal fasciculus, bilaterally. Okay, so we have two Ds, we have one C, two Cs, two Cs, two Ds. Is also Shemi on line D? Okay. if also Shemi is still online and she wants to or he wants to share with us the answer, that's great. If not, actually, could you tell me why you chose D or C? MELF affects both eyes. Indeed, it looks like internuclear ophthalmoplegia. Now, let's discuss the answer. The answer is D indeed. This patient has bilateral internuclear ophthalmoplegia on both the right and the left side. A bilateral affliction of both medial longitudinal fasciculi is seen in two cases: multiple sclerosis or in stroke. This female has multiple sclerosis due to the fact that she has recurrent vision loss that is typical for optic neuritis, and she also has Euthoff's phenomenon. Exposure to higher temperature will aggravate her symptoms. Let's discuss a bit the internuclear ophthalmoplegia effect. These are the lesions of the medial longitudinal fasciculus. As you can see in the scheme, we also saw this scheme so many times. This helps the medial rectus to contract in the same time the lateral rectus contracts. Practically, from our cortex we have an impulse that will go in the sixth nerve contralaterally, leading to contraction of the lateral rectus, and ipsilaterally will lead to contraction of the medial rectus through the third nerve. However, in order to activate the medial rectus, the medial longitudinal fasciculus is required to connect the nucleus of the sixth nerve to the nucleus of the third nerve. These bilateral lesions are seen in stroke or in multiple sclerosis. The explanation is simple. Multiple sclerosis affects various parts of the central nervous system, and in this case she will have lesions on both the left and the right medial longitudinal fasciculus. For stroke, the patient has two separate strokes, one on the left and one on the right medial longitudinal fasciculus. So, was it clear? let me know if you have questions. For the picture, I actually prepared a link that you can access afterwards to see at the physical exam how the patient will manifest. You can save the link and watch it, I think, at the end. I don't know. It is a good example and it will help you on the rotations. I know having strokes bilaterally is quite rarely actually, but in the same time is really, yeah, it's difficult for someone like, probably the most frequent cases of strokes in both MLF are in atrial fibrillation, and they might not be in the same time. Sometimes one of the clots will go and obstruct one of the MLFs, and somewhere along the line the second clot will go and obstruct the other one. Do you have any questions on the subject? With pleasure, P-Chips. Are Lucas, Kanker, Karen, all of the others still on the line? Or did I lost everyone with the internuclear ophthalmoplegia? Actually, it's not it's not an ASD, because in the case of AFib, the clot will go from the left atrium into the left ventricle. From here it will go into the aorta. The clot then continues down the descending aorta, from where we have the the intercostal arteries. From the intercostal arteries, the two arteries of Adamkiewicz will spring and unite into the anterior spinal artery that will become the vertebral artery, and then will enter and irrigate the pons. So this is the anatomy from the first year. Managed to remember the entire circuit. Thanks, Lucas, for the exercise. Okay, are we all good? Can we go to the next question? Okay, let's go to the next question then. A 7-year-old presents with recurrent vomiting at the emergency department. The patient is emaciated. On inspection, there are spider capillaries on his cheeks as well as on his conjunctiva. On palpation, there is an epigastric mass. The child walks with a wide-based gait. Finger-to-nose test shows dysmetria. His labs show an AST of 35 and an ALT of 40. What is the most likely diagnosis of the epigastric mass? It is a non-Hodgkin lymphoma, gastric cancer, hepatitis, or Niemann-Pick disease. We have a B. A D. Okay, Skanker, can you tell us why B? Also, Chips and Karen, can you tell us why D? And Lucas, can you tell us why ataxia? No, wait. Why you chose an answer? Okay. The answer is B, gastric cancer. The patient has Ataxia-telangiectasia. Patients with Ataxia-telangiectasia have a high risk of developing non-Hodgkin lymphomas, leukemias, and gastric cancer. Based on its location, meaning in the epigastrium, there is little chance that there is a non-Hodgkin lymphoma. On the other hand, it can be a gastric cancer. How do we know he has ataxia-telangiectasia? Well, he has cerebellar ataxia. The finger-to-nose test shows dysmetria, and he also, the boy, has wide-based gait. Also, ataxia-telangiectasia presents with telangiectasias of the eye and the skin. Ataxia-telangiectasia is an autosomal recessive disease. There are mutations in the genes repairing the double-stranded DNA breakage. Ataxia-telangiectasia, as we discussed, is a risk factor for leukemias, non-Hodgkin lymphomas, and gastric cancer. There is no treatment for ataxia-telangiectasia. However, if there is a severe immunoglobulin deficiency, we administer IVIG. The next question is, what other consequence is seen due to the fact that there is a defect in the gene repairing the double-stranded DNA breakage? Niemann peak. Okay. So we have skin cancer, pyoderma something. The fact that we have a defect in the gene repairing the double-stranded DNA breakage, it means that there is a higher occurrence of the double thymidine, the double T, uniting. Wait a moment, do we have other messages? Pyoderma. Okay. Now, discussing the answer to the question. A defect in the gene repairing the double-stranded DNA breakage will lead to accumulation of thymidine bridges. These thymidine bridges are usually caused by exposure to UV light. This means that there is a propensity to sunburns, but also there is a propensity to develop skin cancer due to the fact that there is no repairment. So shout out to Karen, who actually answered first. Yep. And now, is everyone there? Skunker, Chips, Lucas, Karen? Perfect. Now we have a surprise section. I know that some of you will have an exam that is coming, and there is a problem with biostats, so we will have a question from biostats. I hope I got you thrilled. Let me know when you are ready to see it. Okay, so let's pursue the question. A study is conducted to find if there is any association between caffeine consumption and lifespan. A control group of consumers of decaffeinated coffee and a case group of coffee consumers is selected within the Chicago area. The objective of the researchers is to have the highest external validity. Which method will be the fastest way to maximum external validity? A. Both groups will be put together and then sorted based on various demographic strata: age, gender, socioeconomic status. B. Each subject from the control group will be matched with a subject that has similar demographic traits in the case group. C. Each group will be split randomly in half for comparative analysis. So we have three B's, Skunker and D'Angelo. Do you have an answer? Okay. Now, let's discuss the answer. B, the answer behind B stands for matching. You were right in the aspect that this is matching. A, on the other hand, is stratification. The question was the fastest way to maximum external validity. External validity means that we can generalize from the population we studied to a greater population. In this case, it means that we can generalize from the Chicago area to any other metropolitan population, for example, the New York area. There are two ways in which we can get maximum external validity. The first one is matching. Matching means that we take one person from the control group and one person from the case group that have similar demographics, meaning age, gender, socioeconomic status. Then we also have stratification. That means that before doing the analysis, we will stratify the population by age, gender, socioeconomic status. In summary, when performing matching, we do the analysis as we might match every person with someone from the control group. In the case of stratification, we first stratified the entire population on various strata, and then we performed the analysis. The problem appears that if we want to have maximum external validity, we need to add another step to the matching process. Namely, after the analysis from the match, we need to weight that population. For example, how many people that we matched with the age of what is the proportion of the people that we matched that are 75 years old corresponds to the population. And we will know that 75 men from the population have the age of 75. Then we will weight it by the entire population. So if the entire population is 150, then we have 75 under 150. This is the weight that we have to multiply with when doing the comparative analysis. As I've told you, the answer was A. Stratification differs from matching through the fact that it does not require weighting. We already made this weighting by putting them into strata. Weighting is a process through which of the matched pairs has to be given an index number based on how much the pair represents from the general population that was selected from. Both solutions are used for maximum external validity. However, stratification has already weighted the results. So let me know if you have any questions. I hope you were on track with me on this one. the choice for this question was to give something that can be tested on the USMLE from biostats, but in the same time that is not heavier, that is harder than the usual biostats to be more prepared actually for easier questions. Okay, so now Q&A. Do you have any questions or answers? Why not? I would also appreciate your feedback on this course. Let me know how you find it. Also, if you are part of the newsletter, let me know any feedback you have on the newsletter and on the course. And indeed, what else? Thank you, Skanker, for mentioning that one. For the newcomers, if you want an OBGYN video on the fetal heart rate, I put the link here. If you want me to send it in the chat, let me know. And also, if you want to, because it's tied into neuro, if you want to see the video on the fundoscopic findings, I can also copy the link into the chat. Let me know. So guys, thank you for coming to the course. If you want to come to the next one in 2 weeks, there will be another topic inquiry on Reddit. You can vote on it and you can then participate to it. Also, let me know on Reddit messages if you have any feedback and any other ideas for the course, or through the email if you are part of the newsletter. See you in 2 weeks. Hopefully you'll tune in. Bye Karen, bye Chips, bye Lucas, bye Skunker, and good luck to those who have the step 2 CK in the upcoming weeks.